normal placenta. It's supposed to be attached to the uterine wall. The placenta feeds the little baby, gives it nutrients and oxygen through this little umbilical cord. Now, in the event we have an abrupto placenta, or a separation, a disconnection, an abrupt disconnection of the placenta, we can have a number of different things going on. But the big thing is that if we can have a partial separation versus a full separation means that the little baby, the little fetus, will have fetal death. And it's not a good outlook. So if your patient smokes, or does cocaine, or has severe hypertension, and in most cases where I work in terms of the ER, we have a lot of trauma patients coming through that would get in a car accident, or fall off of something, or fall down the stairs, and have a complete abrupto placenta causing fetal death. And that's very, very sad, I noticed. But some data that your patient comes in with, they can have pain, a lot of pain. Think of it like we're pulling a scab off of the uterine wall. If we're pulling a scab off the uterine wall, that's very, very painful. Sometimes we will have a bleeding, but not always, and I say not always, because, for instance, if we had a partial placenta abrupto, meaning that only a portion of the placenta got taken off of the wall, we can have bleeding underneath this partial separation. Or we can have bleeding around the partial separation, filling up the uterus. Now, if this happens, your patient might go into hypovolemic shock. That's the one. Hypovolemic, not a lot of blood volume inside the vessels. You're not going to see bleeding, but your patient still is bleeding on the inside. So we're going to do an abdominal assessment. Is it hard? Is the blood pressure going down? Is the heart rate going up? Trying to get oxygen to the rest of the body. Is that happening? So those are our biggest signs and symptoms of an internal bleeding from abrupto placenta. So just know for your test, we had placenta previa. It's like a preview. It hasn't broken anything. It's not disconnected. That's previa, which is blocking our openings here, or close to blocking. Abrupto placenta means that it's abruption, it's stopped. We are tearing like a scab off of the wall of the uterus. And if we have a complete abruption, the baby will die, and it's very sad. Let's see here. Now for a partial abruption, if you see late decels, the heart rate is going down in the baby. Or if you see a bradycardic baby, a low heart rate baby, you're probably going to have to do a C-section immediately. And this becomes very tough, especially when your baby is 8 weeks out from being born. That's a very premature baby. So there's going to be a lot of complications when the baby's born because organs are still being developed. So, abrupto placenta, and let's go into our next topic here. Adolescence and pregnancy is a population that experiences, for some reason, a low birth weight in terms of when they give birth. So, 18 years old teenager gets knocked up, gets preggers, and we get a pregnant girl that doesn't have the right eating habits. She, let's say, smokes because she's cool and she's like that little teenager. It's a rebel. And she eats fast food and doesn't drink enough water and likes to booze it up every now and then, underage. I'm not saying all adolescents are like that, but only the adolescents I meet are subscribed to adolescents themselves, where am I going with this? Okay. Okay, less than 18 years old is a teenager. The thing you have to watch out for is low birth weight. Now, one of my aunts had a child, I think, at the age of 16, and I think it was my aunt's, like a far distant aunt. I think they actually lived in Mexico or somewhere, but I guess at 16 she had her first child, and came out fine and everything. But the population of adolescents themselves usually have low birth weights, and this can be just from either dietary problems or not having a mature enough body to take care of an actual baby. So prenatal care is a huge stressor here, as well as nutritional coaching. Many times if you're in your metropolitan areas, someone in their teens gets pregnant, and we don't take the proper prenatal steps. Like, when was the last time a teenager is actually responsible with even their chores or something? And we're talking about taking care of a child. So going and getting active prenatal care is huge in terms of education. Going to the clinic, getting the folic acid and prenatal vitamins they need to prevent complications like spina bifida, or getting themselves checked for STDs so it doesn't come out of the birth canal and make your patient blind. But nutritional coaching and prenatal care are really, really big factors we have to stress with our teenager population. And if you guys remember both of the low birth weight for your test, that will probably get you points. So next is our substance abuse here. So we're going to be talking about AIDS and pregnancy here. So our patients can get pregnant with any pre-existing conditions. So some patients with AIDS get pregnant, and we know that all the blood in the body circulates with the baby and back out again. So the baby has a possible chance of getting AIDS. Not a guaranteed thing, but there are a few things that we do in the medical profession to make sure that the baby is at least risk as possible. So one thing that we can do is have no breastfeeding. So no breastfeeding, and I can't believe I actually drew a picture of it. Whoever told me to do OB and pediatric was great. So no breastfeeding, just like the little sign at the park, no feeding the ducks. No breastfeeding. We want to make sure to monitor your T cells in your mom, okay? Monitoring the T cells. And if you guys had your AIDS lecture, it's okay if you haven't. But fancy words for it, our T cells should be above 500. They protect us. When they go lower than 350 is when your AIDS patient gets signs and symptoms of infection. So we have a risk for, and I didn't even put it here, infection. Big risk. And we know that infection in the mom, if it goes septic, can induce the patient, the little baby, with more late D cells, less oxygen, and even fetal distress. So T cells, keep them above 500. We don't want the mom to become infected in terms of any type of other opportunistic infection. Fancy words for anything that can get your mom sick. And then we want to give the medication AZT. This is ongoing. It helps prevent the transmission of AIDS into the baby. So again, no breastfeeding, and keep the T cells above 500, guys. All right, so we're talking about amniotic fluid embolism is our next subject here. This is what happens when the baby's amniotic fluid, well, actually not the baby's, the amniotic fluid inside the uterus comes out and mixes with the mother's blood. Now, the pathophysiology behind this is not really fully understood in the medical field. We think that it's an allergic reaction with the mom, but what happens happens is the mom and the baby have an 80% chance of mortality. Because once the mixing of the amniotic fluid goes into the mother, they think it's an allergic reaction. So we have chest pain, chest discomfort, we have a drop in blood pressure. So we're thinking that the vessels become dilated. We have respiratory distress. So this is a 911 emergency. We are calling the doctor, getting him to the bedside. And what we're going to be doing is preparing for life-saving maneuvers. So advanced life support here, ACLS. If you haven't taken your ACLS, then it would be a good time to renew it because most nurses, L&D nurses, need ACLS. So if you're going to be an L&D nurse, we're going to have you ready with CPR. We're going to do a blood transfusion to get all that amniotic fluid out of the body and mix it with blood. Now we're going to provide O2 and an IV line to support with our blood transfusion. We don't know, but your patient might even get an ET tube. But again, it's only 80% chance of mortality. So that's our amniotic fluid embolism, which is a medical emergency. We're going to do induction of labor next. Ectopic pregnancy, echo. Okay, so ectopic pregnancy, I like to remember ectopic pregnancy as like an echo, like you're shouting out to the little fetus, because the fetus is not growing inside the uterus. It has started growing inside the fallopian tubes here. Fallops. It has started growing outside of the uterus. Now the uterus is supposed to be the area where the little baby is supposed to be, it's a little house, it's a little apartment. And our cervix is the door, and the little placenta is stuck on the side of the wall, and it gets food and nutrients through the little umbilical cord, yada, yada, yada. I always have to go over the patho for you guys, I'm sorry. But when your baby starts growing outside of the uterus, usually it happens in the fallopian tubes, and the baby can start growing, and usually if you do not catch it by week 12, this fallopian tube can rupture, and yeah, it'll like blow up, and yes, it's a lot of pain. So abdominal pain, like times 10,000. There you go. That's 10,000 for you. Okay. You're gonna have a rigid, tender abdomen, internal bleeding, guys. Internal bleeding. You have a freaking ruptured fallopian tube. That's bad news. So your internal bleeding, you'll have a very rigid abdomen. So when you do your abdominal assessment, if your patient's abdomen is very rigid, very, very painful, that could be a big indication of internal bleeding. Not just with fallopian tubes. It could be, let's say, if someone has a gunshot wound or a stabbing. Very rigid, probably internal bleeding. This internal bleeding can lead to shock. Shock, just fancy words for decreased blood volume, and it always is because of decreased oxygen. So don't forget our H&H, hemoglobin hematocrit. Your hemoglobin carries the oxygen around the body in the little wraps of the red blood cells. So hemoglobin are those little carriers for oxygen. So just like this. So if we don't have any more, or basically we have half of our oxygen carriers, we're going to have low oxygen, and your body's going to start shutting down. So, your patient's bleeding out, you're going to have decreased blood pressure, increased heart rate. Increased heart rate. You're going to have less oxygen being pushed around the body. Your heart's trying to push what it has around the body. The blood pressure, there's not a lot of pressure because we lost half our blood volume. I'm not saying half, I'm just saying. We could have lost half our blood volume. Just depends on what the H&H is, the hemoglobin hematocrit. So we're going to monitor for your bleeding, and we're going to have to go to surgery immediately if your patient has a ruptured ectopic pregnancy. Now, hopefully we get a surgery. Hopefully we get a ultrasound before your patient has any type of rupture in the fallopian tube. Hopefully the morning sickness and the mood swings and all the other abdominal pain going on alerts your patient to say, hey, maybe I might be pregnant. Let me get this checked out. Let me do a pregnancy test. Because in the ER, we usually just find these fallopian ectopic pregnancies in an ultrasound. So it makes it a lot more simpler catching it early. So that's it for ectopic pregnancy. Let's go into our next topic. Fetal distress. Well, a lot of people use that term fetal distress, not really well defined in the medical field. So fetal distress can mean a whole bunch of different things. Just like if a kid goes to his mom and says, hey mom, I'm sick. I mean, sick can mean anything. Sick can mean, I don't want to go to school that day. Sick can mean he wants to stay at home, eat cereal. It can mean a lot of things. So fetal distress itself falls under a lot of categories. It basically is a general blanket term that we use to say, hey, the fetus is not doing well, mainly because we have a decrease in one of these three areas, or an indication in one of these three areas. Now, for the big thing is fetal movement. We want to make sure that your baby's moving. If your baby's not moving, or the fetus is not moving, then this shows that your fetus might be under a type of distress. We have to educate our moms to monitor fetal movements. Fetal movements meaning that we feel the little fetus kicking. And it has to be at least 5 times, and they can check, it has to be 5 times within an hour. They can check at least 2 to 3 times a day. And I know this is a subtle type of sign or symptom, but usually the moms feel their little baby kicking a lot throughout the day, especially if we're up and moving around. Obviously, it's always going to be fetal heart rate, late D cells. We're monitoring our patients, our little fetus. If it has a deceleration, fancy words for a bradycardic moment from the baseline, at least 20 beats consecutively, this is our late D cells. So that can indicate a fetal distress as well. And even in labor, if we have meconium staining, the water broke and the water's supposed to be clear, amniotic fluid. If it's brown and meconium, basically meaning poop, if the fetus has pooped inside of the little jacuzzi of our uterus, the baby could aspirate that, and that could be a form of fetal distress as well. So what do? Well, we monitor our patients. The biggest thing with the NCLEX, the biggest thing with your nursing tests, is they want you to follow nursing process. Data, action, response. So never do an intervention before an assessment. You can call it ADPI, you can call it SOAPy, but always do your assessments first. So we're going to assess our patient, monitor your patient. We're monitoring for late D cells. We're monitoring for fetal movement. Then we are doing the assessment of laying mom on the left side, taking the pressure off of the vena cava of the heart. Vena cava is the entrance to the heart, so we want the blood flow to go back to the heart, help mom to breathe, get blood to the lungs, and pump it out through the lungs. Okay? So taking all this pressure off the heart, put mom on her left side, and that's always, honestly, the go-to. Always going to do that in labor. Taking mom off of her back, putting her on her left side. We want to take that pressure off the heart. Then we're going to give oxygen to mom. Just just like following our ABCs, airway, breathing, circulation, we're going to give O2. If we continue to have late D cells, if we continue to have decreased movement, there's nothing we can really do about the meconium staining, but if we continue to have these two, we're going to have to go to OR and have to either induce labor or get an emergency C-section because of these two factors here, okay? So that's what we do for fetal distress syndrome. So diabetes and pregnancy. So diabetes and pregnancy is our next video here. Now there's a number of reasons that can predispose your patient to becoming diabetic during pregnancy. That's called gestational diabetes. You also have type 1 diabetes and type 2 that happen before pregnancy that can still be affected from the pregnancy itself. So the pathophysiology behind gestational diabetes is we have the mom creating all these hormones. We have the HCG, we have increased estrogen, increased progesterone that are helping the development of the new baby. But this increase in estrogen and progesterone sometimes has a negative effect on letting glucose inside the cell. So as you guys remember from your diabetes lectures, you eat sugar, we eat carbohydrates, goes into our body, and then our pancreas, right here, it creates insulin, and insulin is that key that opens up our cell and lets glucose in, yeah? So if we don't have insulin, or basically, if our insulin is being resisted by the broken locks on our cell, our progesterone and estrogen are getting in the way, and they're clogging up that keyhole right there. Let's say it's blocking the lock, and insulin is not effective anymore in terms of getting in glucose. That is going to put more sugar into the body and not into the cell. So you can just see like estrogen and progesterone and the hormones of this pregnancy is blocking the lock of the cell and not letting insulin open it up. That's the way you can think about it. Now, this increase in glucose now is not getting into the cell. We have this blocked lock. So this increase in glucose is now floating around the bloodstream, clogging up everything that glucose does. And if you guys seen any of my diabetes lectures, increased sugar in the bloodstream, it makes the bloodstream very, very sugary. So you have an increased risk for infection. It makes the blood very thick. You have an increased risk for hypertension. It makes the blood very, very thick, syrupy, and has a breakdown in terms of all the other aspects of our organs. But the main thing is, we also have a new baby in the mix now. So it's going to push nutrients to the baby. And this extra glucose acts like more, almost like, what is it called? Miracle growth. It acts like a hormone, a growth hormone, that makes the baby really big. And it comes to a condition called macrosarcoma. Macro meaning big, so you have a bigger baby. Like miracle growth, you're pouring fertilizer on like a little flower. So this comes at risk with the baby, and we have a lot of other defects that can come along with macrosarcoma. So it not only affects the mom, but it affects the baby itself in terms of getting that baby bigger. So what do we do? How do we know if your patient is going to have gestational diabetes? Because once gestational diabetes, once the delivery is over, gestational diabetes goes away. So, how are we going to do? We're going to test with a glucose tolerance test. We're going to give your mom a very, very sugary drink, and we're going to have the mom drink it down. So, we want the blood sugar to come low, And if it lasts longer than 3 hours and your blood sugar is still above 140, then you're diagnosed with gestational diabetes. If we give you the sugary drink and the progesterone and estrogen is letting the cell in, letting the insulin open the cell, and glucose is going in, all that sugar is going inside the cell, then you probably don't have that bad of an estrogen progesterone problem blocking the cells, aka we don't have gestational diabetes. But if your 140 is really high after 3 hours, that means that our insulin not opening the cell, not letting the glucose in. I said it again and again and again. So we're going to teach our patients who are diagnosed with this gestational diabetes. We're going to teach them about carbohydrates, watching out for having those simple carbohydrates, watching out for simple sugars that increase the blood sugar in your body. We're going to educate them on high fiber that slows and lowers the glycemic index. Fancy words for it brings your blood sugar low and stabilizes your blood sugar. Another fancy word for there's no sugar in the blood now. Okay? So medications we're going to give your patient is insulin only for gestational diabetes. Insulin only. Any of the other oral anti-diabetic agents like metformin, glyphosate, or any other oral medications can be very detrimental to the baby. So that is for our diabetes and pregnancy. Hydatidorm is our next topic here. Hydatidorm is what's known as our little grapes. We call it hydatidorm mole, and the mole, you guys think of someone having a mole? It's very round, it looks like a little ball. That's what happens with the developing fetus. Now it starts off as a good pregnancy, the sperm and the egg, conception, and things start happening, but cells start reproducing in the wrong way, and we get these little balls filled with fluid that produce HCG. And HCG is that hormone that your moms create to help protect the baby and for fetal development. But a big thing is that the HCG is produced at high levels. So it's very sad in the first trimester, the first 3 months. The mom comes in and says, yes, I'm having a baby, I'm pregnant. I got HCG on my little pee strip for my pregnancy test. I'm gonna have a baby. Go take an ultrasound, and all we see is these little grapes, hydatidorm mole. It's not so fun. So this usually happens with our women over 40, and a big detection is spotting during pregnancy, blood during our first trimester here. So one thing that we're going to do for our indications here, in terms of our interventions, medical interventions, is we're going to do a DNC, a dilation, and then we're sucking out the grapes. And once we do this, we cannot have the patient get pregnant for up to a year. That's one of the big indications there. Because hydatidorm mole can also be caused in terms of a type of cancer. It's not always cancer. If it is cancer and goes down that road, your patient will have to do chemo as well as radiation. But regardless, we're going to have to dilate that cervix, which is the door to the uterus, and suck out all the grapes here, all the moles, and then we can't have your patient get pregnant for up to a year. And that's what we have to do for our patient education. So that's hydatidorm mole. Our next topic is excess nausea and vomiting, hyperemesis, too much emesis coming out. This is mainly due to a reaction to HCG. So whenever your patients or even your family members, or let's say your sister-in-law or Nancy down the street has a pregnancy and they say, oh, you're going to wake up with morning sickness, or you're going to have this, you're going to have that. Some females, they have great pregnancies. They don't have nausea and vomiting, They have great reactions to HCG. Some have bad pregnancies and have nausea, vomiting every day. And some have really, really bad pregnancies that can lead to fluid and electrolyte imbalances, fluid volume deficit from too much emesis coming out of their body. And it's all mainly due to a reaction to HCG. And HCG is that hormone that females create when they have a baby, or when they have one or the other. And this HCG helps to protect and helps the fetus to develop. So, if we have too much nausea, vomiting, we're going to have a fluid volume deficit. We're also going to have electrolyte imbalances. If you guys remember anything from your fluid and electrolyte days, you know that your electrolytes reside in your GI tract. So we have our stomach and we have our lower GI tract. So when your patient is vomiting, the two main ones we're going to lose is sodium and potassium. This is your king and this is your queen of electrolytes, sodium and potassium. So with this, we're not going to have adequate amounts of energy. The heart might go into dysrhythmias. The heart might not pump as adequately. Or you can even have very severe hyponatremia and even a whole bunch of other complications. Now, I got like 12 videos on fluid and electrolytes, so I got you covered. But for this test here, fluid and electrolyte imbalances for your hyperemesis patients. Now, if it gets really, really bad, like really bad, and I've seen patients in the ER really bad, we would have to give them an IV that would eventually be a central venous catheter or even a PICC line, where we would put it up the bicep of the vein here, and we'd give them TPN, total parenteral nutrition. And we'd have to give all their food through an IV because they couldn't keep anything down because of the bad reaction to this HCG would make them throw up. So keeping your patient NPO in that scenario is probably the best thing for your patient, as well as having any type of antiemetics like Zofran or Compazine or even Reglan would be great. So that's it for hyperemesis. Placenta previa is our next topic. Now, I know this looks like a little astronaut on the outside of Earth, but it is our baby inside our uterus. Let me bring it here. So placenta previa is like a preview of the placenta. Basically, the placenta is getting close, either marginally close, partially close in terms of covering our opening, our little door. And if you can kind of see the door I drew, this is our cervix, the cervix door. Or it's completely covering our cervix door. So by the time your patient is going to be delivered, there's no opening for the little baby to go through. That's why if our door to our uterus is blocked, there's going to be a mandatory C-section inside of scheduled for your patient. Now, just like I say in every other diagnosis, there can be a small, medium, or large. Just like if you're going to order a hamburger, you get a small, medium, or a large supersize me. That's our complete. So if you just think of it like that, that'll be a lot easier. So for bright red, if your patient comes in complaining of bright red, the big key word here is painless. Painless bleeding. That's huge. And I say it's huge because in abruptio placenta, that's when the placenta detaches from the wall of the uterus. That's when it's a lot painful. It's like we're ripping off an old scab. So right here, the placenta's just chilling. It's like it's not doing anything. Just relaxing. So it's very painless bleeding. You want to tell your patient to get bed rest. And in terms of your test, a nursing intervention that you do not do is vaginal exams. Don't do it as a nurse. Only the doctor is supposed to do that. And we started doing this because too many nurses were having a rupture of the placenta. So no badge exams for the nurse. So do not choose that one in terms of your interventions, okay? Nurses can't do a lot of things. Only doctors are allowed to do, and this is one of them. So no badge exams. So next, guys, is our abruptio placenta, or pulling the scab off, pretty much the uterine wall here. Today we're going to be talking about abortion and our complications of our pregnancy. Now, before you even think of the word abortion, all that really means is medical terms for miscarriage. So abortion is not, it's not always what we call elective. It's not always induced. It's not always a choice. Sometimes your body doesn't agree with the fetus growing inside of it. Sometimes the fetus is not compatible to life. So there's 3 stages of abortion, or 3 categories, if you will. We have spontaneous, and that is the biggest category here. We're going to go into that. You have therapeutic, basically meaning that the fetus inside is not able to be compatible with life. For instance, the brain's not cooking right, or basically growing right. Maybe the lungs or the heart have defects and the baby dies. Then there's elective, which is very political. Should the woman have the choice, or should the government prohibit anyone from wanting to have an abortion? So we're not going to be talking about these last 2 today. We're going to be talking about the biggest one here, and the one that you're probably going to be tested on in nursing school, which is your spontaneous abortion. Spontaneous meaning that your patient's, the woman itself is rejecting the fetus. So before we even go into it, I drew a little bit of a cervix for you and a uterus, and I never wanted to do these videos. I don't think, I got so many requests for it though, and I'm like, no, this is my worst subject, and I hate it. But, you guys requested it, so, yeah. All right, here we go. I'd rather do an enema video than this, okay? All right. So we have here's our patient here. Here's a thigh, the butt cheek, and then we have our bladder right here, or urethra, which is separate from your vagina, of course. At the end of the vagina, we have your cervix, and the cervix is just like the door, or like the driveway to the actual uterus. And the uterus is where the baby is cooked, or basically where the baby is made. A little oven, we call it. Now, this threatened abortion basically means that it's a possibility to have a miscarriage. Threatened abortion, your patient might come in for having excessive bleeding, excessive cramping, and let's say they're only in the first trimester. So they're in the first 12 weeks of their pregnancy. Well, we're going to do an ultrasound. We might even do a vaginal ultrasound, and we can see if the cervix is closed or if the cervix is open. If the cervix is closed, this is what's known as a possible abortion, or what's known as a threatened abortion. Because this door is closed, which means the baby's not coming out yet. So all we have to do is slow down the contractions, slow down the bleeding. For the contractions, we're probably going to give magnesium sulfate. And magnesium, just think about a big magnum. And magnesium is that electrolyte that's like a gun at the electrolyte party. If you pull out a big magnum gun at a party, everyone calms down, right? There's not going to be a whole bunch of people jumping around having a good time when you pull out guns. So when you pull out magnesium inside the body, like magnesium sulfate, your uterus is going to stop contracting and it's going to calm down. It's going to take it down a notch. So that's why we give it for our threatened abortions if we have too much contraction. So just remember that the cervix is closed here. For our inevitable abortion, our cervix is open. It's open. So there's no stopping this type of miscarriage, aka inevitable abortion or inevitable miscarriage. Because there's an opening which is not holding the patient or the fetus back. Anything and everything will come out. And so we can't control this inevitable. It's going to happen. With threatened, we can give medications to slow down the contractions and to hopefully keep that fetus in there. Okay? So in inevitable, let's just say the patient or the fetus itself has deceased and an inevitable abortion happened or a spontaneous abortion happened, aka miscarriage. And now you have two categories here. You have an incomplete miscarriage or you have a complete miscarriage. Incomplete basically means that the pieces and fragments of the little fetus, I know it's horrible to think, I know it's it's difficult, especially it's difficult for your patients. I mean, think about it. If they just got pregnant and they're expecting this little baby, and by the way, all these are the first trimester. So in the first 3 months. And they're so excited, and now they have to deal with a spontaneous miscarriage. That's really hard. So incomplete means there's pieces and fragments of the placenta or the little fetus still inside the patient or the woman. We're going to need to deliver those. We're going to need to dilate the cervix and have a vaginal delivery of the pieces and fragments of the fetus. If we leave them in there, these pieces and fragments of the placenta or the fetus will cause your woman to be septic. And a full bloodborne infection can happen. And we've even seen women die in different countries who don't deliver after an incomplete miscarriage. A complete miscarriage, or aka complete spontaneous abortion, means that 100% is delivered. You've gotten everything, the placenta, as well as the fetus, out of the body, and you can try again in terms of your female patient can try to have kids again. So, again, threatened means that it's not a guaranteed miscarriage. The cervix is closed, which is good. Give some of that magnesium sulfate to slow down the contraction. Inevitable means that the cervix is open. It's going to happen. It will happen. Now, inevitable, is it going to be complete or incomplete? If it is incomplete, we need to get those pieces and fragments of the placenta out and make it a complete so your patient doesn't get septic. Cool? We're going to go on to ectopic pregnancy next. So substance abuse is our next topic for our pregnant ladies here. So obviously we know that any consumption of alcohol in excess or even our recreational drugs, cocaine, and even opioids have an effect on your patient's body. Now it becomes a whole lot different when your patient is pregnant. So let's go through a little bit of each one and break down the patho. So for our ETOH users, our alcohol, we know alcohol is a central nervous system depressant. It also vasodilates your blood vessels. So when our patients are getting off alcohol or alcohol withdrawal, we can have vasoconstriction, and vasoconstriction in our cranium which could cause even a stroke or what's called seizures, tremors. And that's kind of what we see if your patient is born with a mom who is on ETOH or alcohol abuse. So we have CNS dysfunction, central nervous system dysfunction, because alcohol is that central nervous system depressant. Next one is our cocaine. Mom can have seizures if she's taking cocaine. We know cocaine is a vasoconstrictor, very tight. Almost like the same effect if you get off alcohol or constricting again, and it could cause seizures. We're not saying it always does, but it could. The baby, a number of things can happen to the baby because we're all vasoconstricted. And that constriction doesn't leave much room for perfusion of the baby. So you can have a miscarriage, you can have a placenta previa, placenta abruptio, fancy words for we're pulling the placenta off the wall of the uterus. And we know that the placenta feeds or helps feed the baby. You can have even neurotubular defects in the baby. So less oxygen going to the baby can cause neurotubular defects, fancy words for spina bifida, or an opening in the spinal column of your baby when he's born. So a big sign with cocaine abuse is the baby will be very irritable, and the baby will be have poor feeding, so low birth weight. And usually our moms don't even have the correct nutrition when they're on cocaine, or they don't have an appetite, so there's going to be a low birth weight anyways. For our patients on opiates, our opiates is our narcotics, our painkillers. Let's say Vicodin, Oxycontin, Percocets, those types of things. Those help block the pain receptors in the central nervous system. So the baby's going to come out with some central nervous system defects. Also, there's going to be high-pitched cry, irritable and poor feeding with the baby. You're going to be able to see withdrawals from the baby within 24 to 48 hours. So what they recommend in the medical field to do is wrap the baby up tight, make sure it's a nice little burrito, and try to feed the baby if you can. Let me see here. After the baby's delivered, we don't want to give your patient to the mother in terms of breastfeeding, just in case we don't know how long your mom has been using for, and we don't want anything to be transferred through the breast milk. Now, we're not saying this is like a wonderful type of pregnancy where it's all been planned out and we have the great care vitamins and awesome checkups. Usually we get patients who have substance abuse or are homeless or are just drug addicts, and they have children, and it's like their sixth child. So you're going to see a lot of things in the nursing field and the medical field itself, but we have to still delineate the same amount of care no matter